get it. So, Parkinson's disease, let's go to the introduction. Why did I focus on Parkinson's and no other topics? Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease. That's why we are dealing with Parkinson's today. Why? Common things are common. So when it comes to approach to ataxia, one thing I know that I need to master, because I'm talking about the second most common neurodegenerative disorder. I'm going into a board exam. Come on. Approach to ataxia is one of them. Second most common neurodegenerative disorder. I'm going to mark it down. I'm going to make sure I eat it, chew it, digest it with all the enzymes before I go into the exam. Doctors, please, are you tracking with me? You see the reasoning why I choose some of the topics we discuss? Because the literature says it's the second most common neurodegenerative disorder. Therefore, I'll make sure that I master it. Now, it's a progressive condition. And there are motor symptoms like tremors, like rigidity, like bradykinesia, like postural instability, and there are non-motor symptoms which affect the quality of life. So when you are dealing with Parkinson's disease, don't think about Parkinson's only in the context of physical symptoms. Most of the time, that is what we focus on. The tremors, the mask-like faces, the drooling of saliva, the shuffled gait, the stooped gait. We see those ones, but don't only look at it in that context. Remember that there are non-motor symptoms that can also come with it. But the motor symptoms are the tremors, the rigidity, the bradykinesia, the postural instability, right? Now, what are the motor symptoms? So I'm breaking it down to motor symptoms and non-motor symptoms. So the motor symptoms are the resting tremors, which are often the first symptoms, and typically they begin in one hand. And it is usually described as pill rolling. So it looks like the patient has a little pill in the tip of the fingers and the patient is rolling it. Number two, rigidity. And the rigidity can come in two ways. We have corkscrew rigidity and clasp knife. So corkscrew rigidity is like, like, corkscrew, right? The way it's, and then a clasp knife is like the way that's like those who have these dagger knives with, so it's like you try to open it, it's very tough, then boom, then it goes away. Okay, so there's resting tremor, there's rigidity, and then there's bradykinesia. That's slowness of movement, and it causes difficulty with activities of daily activities like writing, like dressing, like walking. Okay, and then they can also have postural instability. So there is difficulty in maintaining balance, and it leads to frequent falls, especially in the later stages. So I can even set a question from this. Which of the following is most likely to initially present in a patient with early Parkinson's disease? A, rigidity. B, bradykinesia. C, resting tremors. D, postural instability. What answer will you go for, please? Which of the following is likely to present initially in a patient with early stages of Parkinson's disease? A, rigidity. B, bradykinesia. C, resting tremors. D, postural hypotension, postural instability. What answer will you go for?
Resting tremors.
Resting tremors. Beautiful. Okay. Now, what are the non-motor symptoms of Parkinson's disease? They can have cognitive impairment. So when you're thinking about Parkinson's disease, don't think about only the physical symptoms. As I said, it's a neurodegenerative disorder. Okay, so there can be problems with memory, there can be problems with attention, executive function, okay, which can progress to Parkinson's disease dementia. Now, doctors, which medication did we say can be used to manage Parkinson's disease dementia? Who can help me?
Donepezil.
Come on.
Donepezil.
Now look at the team. Everyone is talking like we attended, Harvard neurology class, right?
Doctor, please, somebody's hand has been up for a question.
Oh, sorry, please. Who is that? Dr. David. Sorry, yes. Dr. David, please. Dr. David, sorry.
Oh, Dr. Brone, thank you. It's actually an old question, but maybe I should just ask at this point because I was waiting for you to get there.
Yeah, sorry about that.
So in the management of Parkinson's, the motor symptoms, You said the initial medication, so best initial should be levodopa, carbidopa, correct?
Medication.
Carbidopa.
Medication.
Yeah. Medication. So when you've given levodopa, carbidopa, and then the patient still has dyskinesia and the motor symptoms are still there, all the resting tremors and all, do you go ahead, so in an option to increase the dose of the carbidopa, levodopa, carbidopa, add amantadine, add entacapone, physiotherapy, what would you say would be the better thing to do for a patient who you've started the medication but isn't necessarily improving?
It will depend on the options I'm given in the MCQ.
Oh, okay.
Yeah.
I'm saying the option like amantadine was given, entacapone was given. They are saying you should increase the dose.
For a medical student, I don't think they'll want to confuse it that much.
Oh, okay. Yeah.
I think, it will be obvious. Say that if you've really learned it, you will know. Because like adding amantadine, entacapone, all of them are adjunctive medications, right? So it will be confusing. And people can debate it left, right, center. And in a board exam like that, it will be obvious, right? To be obvious.
Okay. All right, thank you.
Yeah, at times the way I set the questions, it's just to make it just a bit tough, like, so that it can stimulate discussions and all those things. Yeah. Okay. So what are other non-motor symptoms the patient can present with? Sleep disturbances, which includes REM sleep behavior disorder, insomnia, excessive daytime sleepiness, right? And then autonomic dysfunction, orthostatic hypotension. That's why I said that one of the questions, the patient was trying to get up and the patient was a bit dizzy, right? And they can also have even constipation and urinary incontinence.